Relationship between acute pulmonary embolism and Cteph. Cteph is generally considered to be a rare and late complication of one or more episodes of acute pulmonary embolism that have not resolved despite more than or equal to 3 months of curative anticoagulation. A large prospective international Cteph registry has reported that 75% of included patients had a history of acute pulmonary embolism. In published prospective studies with the diagnosis confirmed by right heart catheterization, the incidence of Cteph after symptomatic acute pulmonary embolism is reported to range from 0.4% to 6.2%. In most studies, Cteph was diagnosed a few months after the index pulmonary embolism, which is surprising because generally Cteph develops after a honeymoon period of several years without any symptoms. Pathophysiology of progression of acute pulmonary embolism to Cteph. In acute pulmonary embolism, incomplete resolution and organization of thrombi when occurs, it will lead to stenosis or occlusion of pulmonary arteries, which will affect microvasculopathy in muscular pulmonary arteries and pulmonary capillaries and venules, which will lead to progressive increase in pulmonary vascular resistance, leading to right heart dysfunction and systemic symptomatic Cteph. Thrombus non-resolution in Cteph. In most patients with acute pulmonary embolism, significant resolution of the embolus occurs with a subsequent restoration of blood flow and normalization of hemodynamic parameters. However, in a small subset of patients, residual organized clot remains attached to pulmonary vessel walls. Macroscopically, these chronic fibrotic clots are yellow, highly adherent to the wall of the pulmonary vessels, and they contain collagen, elastin, inflammatory cells, and sometimes calcifications. Only true thromboembolic endarterectomy can remove these organized clots. These pathological specimens are completely different from fresh clots observed in acute pulmonary embolism, which are of reddish color and mainly consist of erythrocytes and platelets in a fibrin mesh. These fresh clots can be easily detected from the pulmonary vessels. This image shows fresh clots in acute pulmonary embolism and yellow adherent plaque lesion in Cteph. When the thrombi become fibrotic and endothelialized, they no longer respond to thrombolytic or anticoagulant therapy. Occasionally, fresh thrombus is attached to the organized thrombus. Microscopically, thrombotic material demonstrates well-organized fibrous tissue, penetrating blood vessels, elastic fibers, and absence of endothelial cells. There is intimal and medial hyperplasia. Infarction of lung tissue will progress. This image shows histological analysis of autopsy in Cteph patients who had underwent endarterectomy. The first image shows thrombus within the vessel, pulmonary artery. The second image shows media and intimal hyperplasia which is fixed with the coagulant tissue. This is seen at the site of obstruction. And the third image, it shows the site distal to the site of obstruction, where recanalization or angiogenesis is seen. This image shows angiogenesis within the organized fibrin clot within the pulmonary artery. This image shows microvascular disease involvement. The first image shows involvement of remodeled pulmonary arteriole or venule, which is less than 100 micrometer. The second image, after the injection of green dye into the hilar vessels, septal vessels and remodeled small venules are highlighted which is suggesting the involvement of post-capillary vessel involvement. Third image, it shows areas with alveolar wall thickening in the occluded part, and within the capillaries, invasion of macrophages and neutrophils.
Camera is not here. Mobile number, anything is there? Camera is not working. One second. Yeah. 7. Yeah.
Pathophysiology of Cteph
190
by other risk factors.
88
Can patients with
634.
malignancy have increased risk of
Toba.
thromboembolic events
Toba and
resulting from various mechanisms, including activation of the fibrinolytic and coagulation system, acute phase reactions, inflammation, and cytokine production. Inflammation. Uh, there appears to be an inflammatory component to Cteph development with higher levels of C-reactive protein seen in patients compared with healthy controls, as well as significant reduction in CRP after pulmonary endarterectomy. However, elevated CRP is not specific to Cteph, as levels were also elevated in patients with pulmonary arterial hypertension. More recent results confirmed that CRP as well as interleukin 10, monocyte chemotactic protein 1, macrophage inflammatory protein 1 alpha, and matrix metalloproteinase 9 were significantly elevated in patients with Cteph. Another inflammatory marker investigated for a connection to Cteph is tumor necrosis factor alpha. Levels are elevated in patients with Cteph compared with controls and are reduced after pulmonary endarterectomy. In infection, the presence of chronic infection, example Staphylococcus aureus, has been identified in patients with Cteph. Although its relevance is unclear, one study found staphylococcal DNA in 6 out of 7 thromboemboli harvested during pulmonary endarterectomy from Cteph patients with ventriculoatrial shunts. Biological and genetic risk factors for thrombus non-resolution. It has been suggested that patients with thrombus non-resolution could have a hypercoagulability state due to the biological abnormalities. Interestingly, the classical hereditary thrombotic risk factors, example, protein C, protein S, and antithrombotin deficiencies, and mutations of factor 5 and 2 are no more frequent in patients with Cteph than in healthy control populations. The levels of 1 millibrand factor, an adhesive glycoprotein that stabilizes and activates factor 8, were significantly increased in patients with Cteph compared with the healthy controls and patients with pulmonary arterial hypertension. ADAM TS13, a disintegrin and metalloproteinase with thrombospondin type 1 motif, member 13, also known as 1 Willebrand factor cleaving protease, regulates the size of 1 Willebrand factor and plays a fundamental role in hemostasis. Severe deficiency of this factor causes thrombotic thrombocytopenic purpura, which can predispose to Cteph. Mutation of the bone morphogenetic protein type 2 receptor gene has been reported in patients diagnosed with Cteph. Blood groups. Cteph is more common in patients with blood groups A, B, and AB. A European registry suggested that non-O blood group was a significant predictor for the diagnosis of Cteph. Platelet function in Cteph. The observation that platelet activating conditions such as thyroid hormone replacement therapy and splenectomy or risk factors for Cteph suggest a role for platelets in its genesis. Studies in a mouse model of impaired thrombus resolution suggested that the initial increase in thrombus volume after splenectomy is due to platelet activation. Surgical materials extracted by pulmonary endarterectomy from patients with Cteph contains increased levels of platelet factor 4, which is released by platelets at sites of injury. These observations suggest a role for platelet dysfunction in the pathology of Cteph. Impaired angiogenesis. Studies in animal models of impaired thrombus resolution have indicated that impaired angiogenesis and recanalization of the thrombus could be involved in the pathophysiology of Cteph. An endothelial cell-specific deletion of kinase insert domain protein receptor ablates thrombus angiogenesis and delays thrombus resolution. The paucity of vessels in pulmonary endarterectomy specimen suggests that deficient angiogenesis is a key mechanism in occlusive vascular remodeling after venous thromboembolism. These findings suggest that medical conditions associated with Cteph, such as splenectomy, infection, or abnormal phospholipid species, may be compromising early thrombus angiogenesis, an important step in the thrombus resolution. Furthermore, increased levels of angiostatic factors such as platelet factor 4, collagen type 1 have been identified in surgical pulmonary endarterectomy material from patients with Cteph and are associated with decreased angiogenesis and or proliferation and migration, possibly resulting in inadequate recanalization of thrombotic material. Platelet endothelial cell addition molecule 1 and thrombosis. It is a glycopeptide receptor expressed on platelets, endothelial cells, and many other cell types. It is involved in leukocyte transmigration and responses to inflammatory stimuli, key components of venous thrombus resolution. Human unresolved deep vein thrombosis specimen showed accumulation of the cleaved form of PCAM1, and patients with delayed thrombus resolution had significantly increased plasma levels of soluble cleaved PCAM1 compared with those whose thrombi resolved. White and red thrombi from patients with Cteph show reduced PCAM1 expression compared with unthrombosed vessels, implicating PCAM1 deficiency in the pathology of Cteph. Molecular mechanisms of small vessel disease. Recent evidence suggests that the involvement of nitric oxide soluble guanylate cyclase and cyclic guanosine monophosphate pathway in the pathophysiology of Cteph. Nitric oxide produced by vascular endothelium inhibits platelet aggregation and growth of smooth muscle cells. Nitric oxide also activates soluble guanylate cyclase to synthesize cGMP, a second messenger with many actions, including smooth muscle relaxation. Plasma levels of asymmetric dimethyl arginine, an inhibitor of nitric oxide synthase, are increased in patients with Cteph versus controls, and reduced endogenous nitric oxide levels have been found in patients with pulmonary arterial hypertension and Cteph. The vascular remodeling in Cteph may indicate dysfunction in anti-proliferative mechanism, including the nitric oxide pathway. The clinical and hemodynamic improvements seen with a soluble guanylate cyclase stimulator, Riosicat, in patients with Cteph who are ineligible for pulmonary endarterectomy or with persistent recurrent pulmonary hypertension after surgery also suggest an important role for the nitric oxide soluble guanylate cyclase and cGMP pathway in the pathology of the condition. Levels of endothelin 1 are elevated in patients with Cteph and in animal models of the condition. Recent evidence suggests a potential role of ET1 in smooth muscle cell proliferation within the chronic clot in Cteph and in small vessel disease. The phase 2 randomized control trial, MERIT-1, performed in inoperable Cteph, showed that the endothelin 1 receptor antagonist macitentan improved 6-minute walk test and pulmonary vascular resistance as compared to the placebo. Increased levels of angiopoietin 1, a signaling molecule involved in angiogenesis and smooth muscle cell proliferation, have been identified in the lungs of patients with Cteph, and high preoperative levels of angiopoietin 2 are correlated with worse outcomes of pulmonary endarterectomy. RV failure in patients with Cteph. Cteph is characterized by a chronic increase in RV afterload, and wall stress. Initially, these burdens result in RV hypertrophy characterized by increases in RV wall thickness and cell size through the addition of sarcomeres. At first, the increase in RV wall thickness results in decreased wall stress and improved pumping effectiveness by unloading of the individual muscle fibers, and RV function more closely resembles the left ventricle. These changes are referred to as adaptive remodeling. This process is not limited to patients with Cteph, but also occurs in patients with pulmonary arterial pressure less than 25 mmHg and chronic thromboembolic disease. The adaptive changes described earlier can maintain RV function for a time, but the RV is not capable of sustaining long-term pressure overload, which increases further during physical activity. Moreover, progressive remodeling of the initially patterned pulmonary arteriolar bed imposes a continuously increasing burden on the RV, leading to its maladaptive remodeling. This is characterized by eccentric hypertrophy, RV dilatation, reduced RV contractile, contractile force, diastolic dysfunction, and myocardial fibrosis. RV dilatation increases wall tension, which increases oxygen demand and decreases perfusion, leading to a cycle of further compromised contractility and dilatation. Decreased RV stroke volume, reduced pulmonary blood flow, and underfilling of the left ventricle leads to systemic hypotension and worsening of RV coronary perfusion. Progressive dysfunction ensues, ultimately resulting in RV failure, which is the main cause of death in Cteph. The time course of RV failure in response to a pressure overload varies greatly between patients, possibly because of variation in pressure, load, phenotype, and neurohumoral overdrive. While the progression to RV failure is clearly much slower, the sequence of events resembles that occurring in acute pulmonary embolism in many aspects. The two most important differences are the progressive increase in RV afterload induced by ongoing remodeling of pulmonary arterioles and the possibility of adaptive hypertrophy or of RV myocardium. Both are absent in acute pulmonary embolism. In animal models of pulmonary hypertension, disturbed angiogenesis and capillary rarefaction occur in dysfunctional RV hypertrophic tissue, and RV myocardial metabolism switches from mitochondria based fatty acid oxidation to glycolysis. Animal models of pulmonary hypertension have indicated a significant increase in tissue fibrosis in maladaptive RV hypertrophy relative to the levels seen in adaptive hypertrophy. The fibrosis seen is pathological process resulting from upregulation and interaction between growth factors, including transforming growth factor beta and connective tissue growth factor, hormones, and matrix metalloproteinases. Pulmonary endarterectomy improves RV function in patients with Cteph, indicating that pathological remodeling can be reversed. Thank you.
Thank you very
Thank you.
much. Is Julius there? Anybody?
Yes, sir.
Can you hear me?
Yes, Julius was. Yeah. She connected?
I'm there, sir.
Yeah. Did you hear the talk? What are your comments, Julius? You're an expert.
Can you hear me, sir?
Yeah, I can. Yeah.
Can you hear me?
Yeah, I can.
Oh, okay. I think Devsen, you made a really good presentation. The topic was covered very well. I'm really glad that you went into the details of things very well. And there are just a few things which I may want to add. One is to define small vessel disease. This is the disease that affects um, 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 micrometers in diameter. Okay, and it is because of the involvement of the small vessels also in this disease. You have to look at it as a two-compartment disease. You have the larger vessels being obstructed with the thrombus, and the small vessels which are having the additional component of the disease. So that is why riociguat and some of the other drugs are shown to be effective in this treatment. One thing which you haven't mentioned is the role of collaterals in the systemic to pulmonary collaterals in this disease process and its pathophysiology. And it is of particular significance to us because one of the earlier publications which came up in this area is from Professor George Cherian, and which is widely quoted by many authorities in Cteph. So it is something which we all should remember. The presence of collaterals in large quantities between systemic to the pulmonary circulation indicates that there is a low pressure area beyond the obstruction, which otherwise means the patient might respond well to the surgery. If you remove the obstruction, the patient's pulmonary pressure is going to come down if you have a lot of collaterals. And naturally, these collaterals do not continue existing once you re-establish the antegrade circulation. The collaterals will just stop functioning at that time.
Your audio is not working. Hello. Hello. Yeah, some disturbance going on.
Yeah, I think I got logged out of the device.
Okay.
Okay, I was talking about collaterals and
Yeah.
the significance of that. So
These are
if
the
there is a
mainly the bronchial collaterals, is it?
yes, the collaterals come from the bronchial arteries, from the internal mammary artery, and the other intercostal vessels, sometimes from infradiaphragmatic vessels also. And coronaries also form a significant part of the collaterals. If you look at the tracheal blood supply normally also, the lowest portion of the trachea around the carina is got a blood supply from the coronary arteries as well. So all these collaterals that develop are the ones which are already existing, which get larger in size and supply a significant amount of blood into the pulmonary circulation, which is also one of the reasons why we need to do TCA when you're doing pulmonary endarterectomy, because the returns which you get out from the systemic to pulmonary collaterals is a large amount when you do the PE, and that is why you need to go on TCA. Okay. So that's about collateral. So it is a very important thing to assess for collaterals. Professor George Arian used to always insist on injecting the collateral, to the point that one time in our system, we were not doing pulmonary angiograms, but we were always injecting the aorta to look for collaterals, and the mammary injection and a coronary injection. And some of these patients also have myocardial bridging and coronary artery disease and all that. So we routinely do a coronary angiogram in all patients. Another thing which you haven't mentioned in the associations or pathophysiology is the presence of indwelling catheters, such as pacemaker leads, ventriculoatrial shunt in particular. Along with splenectomy, that's the other thing which needs to be added in. When you have long-term indwelling devices, which is sitting in the RV or RA, these can form small thrombi and get thromboembolic disease. And many of the times where you see that it is small, these cause multiple episodes of emboli of small material, which leads to subsegmental disease. That is the usual pattern which you see in patients who develop Cteph following indwelling catheters. Um, I want to ask you, Devsena, what is the difference between the operations which are done for acute PE and Cteph in terms of the name and procedure? If you can't
Sir,
answer, it's fine. Just say you don't know.
for Cteph, pulmonary endarterectomy will be doing, sir. For
Acute
acute
PE.
pulmonary embolism, embolectomy will be doing, sir.
Okay, so what is the major difference in the procedure in CTEP? What is done in addition to the usual operation when you're doing pulmonary embolectomy? Besides removing the visible clot which you see in the vessels, what else you have to do? It's okay if you don't know, just tell me.
Don't know, sir.
So you have to do a retrograde flush from the pulmonary veins, because unlike in CTEF where the tissue is fibrous and you can hold onto the tissue and dissect it off the pulmonary artery wall, in acute PE it is fresh clots. They are friable, so you probably won't be able to dissect into the subsegmental level and take them out. And that is why you need to open the left atrium and flush the pulmonary veins individually so that it retrogradely brings the clots out. They're not adherent to the wall so much, so it will just get flushed out. And we see a lot of clots coming out when we do a retrograde flush when we are doing lung retrieval for lung transplantation. Only thing to remember is when your natural tendency to do a retrograde flush would be to take a line from the pump and flush it. But pulmonary vasculature is not used to that kind of pressure, and it'll end up causing injury to the vessels and severe parenchymal bleed. So you should just use gravity, maybe about 30 centimeters height, for doing any retrograde flush. So that's an important thing to remember. People shy away from doing this because some have experienced this severe bleed from the pulmonary circulation. So that's a okay. Now, also, I don't see if you have mentioned that CTEF is a pre or post capillary form of hypertension, and why would you say it's one over the other? Do you want to answer that?
Uh, I don't know, sir.
Okay. CTEF, as part of the definition, you have to say that it is a precapillary pulmonary hypertension. And by definition, precapillary pulmonary hypertension would require you to have a mean pulmonary artery pressure of more than 20. You need to have a PVR of more than 2 and an LA pressure of less than 15. But now it is increasingly being recognized that you might have LA pressures which are higher than 15 is actually slightly on the higher side, but for definition you've kept it at 15. So if you might have higher than 10 or 12 in patients with CTEF, and it's we also have seen that it's a lot of times you see higher than 15 the wedge pressures. One of the problems is measuring a wedge in CTEF is quite difficult because of the obstructed pulmonary arteries. You do not know if you're actually measuring the wedge because you may not get a vessel which doesn't have obstruction further. So there is a lot of error in measurements of the wedge. Okay. Now about RV remodeling. one of
Yes, sir.
the important things to keep in mind is the coronary artery circulation in the right ventricle normally occurs during the entire cardiac cycle, that is, during systole and diastole.
Yes,
But
sir.
in a hypertrophied RV, the circulation changes to something like the left ventricle and forms the circulation is mostly during the diastolic phase. And when you're doing operations on anyone with hypertrophied RV, this is something you must keep in mind, because if the circulation is happening only during the diastolic phase, it is important to maintain a reasonable diastolic pressure. We tend to use pulmonary vasodilators, which most often are systemic vasodilators also, and end up having a low diastolic pressure and a low SVR. And when that happens, there is a steal from the right coronary artery, and you will not get adequate blood supply to the RV, which leads to further RV dysfunction. So, if we were using a lot of milrinone in the past, but now we don't use milrinone. We tend to use some noradrenaline to maintain SVR and some diastolic pressure. And the next thing I wanted to ask you is, do you get pulmonary hypertension in acute PE?
Yes, sir.
You? What? To what extent do you get pulmonary hypertension in terms of systolic pressures? Okay, doesn't matter. See, in an acute PE, you do not get severe pulmonary hypertension. An RV is not capable of producing usually not more than 50 millimeters of mercury pressure or in response to an acute increase in the afterload. That is the main difference in the architecture of the right ventricle and the left ventricle. Left ventricle can handle a large increase in the afterload without failing on an acute setting. But right ventricle is unable to handle an acute increase in the afterload in an acute setting. It takes time for it to remodel and hypertrophy, and only then the RV can handle the afterload. So, if you find an acute PE patient with a PA pressure of 70 or 80, it is probably acute on chronic. Unless they have had a chronic component or other reason to have a RV which is hypertrophied, they will not be able to produce a pressure of that much. The RV tends to fail if it is required to produce more than 50 millimeters of mercury pressure on an acute setting. Did you understand what I'm saying?
Yes, sir.
Okay. Yeah, I think these were the few things I wanted to mention. Your presentation was otherwise very comprehensive, and congratulations on that.
Thank you, sir.
Yeah, very good presentation. Only thing, we used to think that the condition of Cteph is extremely rare in our country, I think only after we started doing the pulmonary thrombo and diathectomies, we started getting referrals. And now I think investigation of any pH should include investigations like CT angio to exclude Cteph. And you don't have any statistics, but in America, they say the incidence is about 3 to 30 per million population. And very often, the acute pulmonary embolisms do not lead to Cteph actually, because either natural thromboembolic thrombolysis process or because of treatment. Then actually you actually mentioned the proximal thrombus, and then distally the vessels are affected by vasculopathy and remodeling. And also in a patient with some obstruction, the non-obstructed part, that area, because they are subjected to very high pressure because of the pulmonary hypertension, they undergo vascular changes almost like the Heath and the Edwards, like the first stage immediate hypertrophy and the last fibrinoid degeneration. So, and then actually the very importance of the collaterals. Actually, when you do a thromboendarterectomy, you have to get a absolutely clear field. So actually, in the initial stages, before the security arrest, they have done many cases with a balloon occlusion of the descending thoracic aorta just below the subclavian, so that the bronchial collaterals blood doesn't come back into your operating field, you know. But that also, as Julius said, doesn't work because sometimes the collaterals are from the coronary arteries. So obstructing the descending thoracic aorta beyond the subclavian will not work, you know. So to get a good field, the only way we can do it by deep hypothermia, circulatory arrest, multiple if you require, you know.
Many people are reluctant to do TCA
Yeah,
because of the
brain
fear
problem.
which goes
Yeah,
with that. But there is a study called PCOG study which was done to compare the results of pulmonary endarterectomy, which was done under various other techniques, including balloon occlusions and selective
yes,
perfusions and all of that, with TCA. And the study was designed to look at long-term cognitive impairment in both these groups. And it was found that both the groups had improved cognitive function after PEA because they had better oxygenation to their heads following surgery. And there was no significant difference between the groups. So TCA does not cause any additional problem while doing the operation. Yeah, all these other gimmicks do not give you a bloodless field, and it's very complicated to actually perform. TCA is a lot simpler. And in terms of acute PE, the earlier recommendation is that you do not need to follow up acute PE patients long term for development of Cteph because the incidence is small. But now I think the recommendation is to follow them up for development of Cteph. And in our own study, which Dr. Murali Mohan and others have conducted, there was this other person called Tia Sen who was here a long time ago. Tia Sen was the first author to that paper. Murali, Syed, all of them were the other authors. They have shown an incidence of development of Cteph up to 20% in acute PE. Now, if you look across the papers which have addressed this issue, those studies which are based on echo have shown a higher incidence of Cteph compared to what is based on cath. So in our study, it was based on echo, so it might be slightly higher than what it actually is. You should all see the number of papers which have come out of our organization on this topic. We've got at least 15 publications. When you all pass out from here, um, everyone expects, or your next employer will expect you to know everything about CETUS because you came from NH. They will also expect you to know everything about ECMO when you go from NH to another place. And
any
you have
questions
to.
or doubts you can
Yeah.
ask Julius.
Anybody has any questions on this? Devsena, you have anything more to ask?
No, sir.
So next will be on the operative procedure, pulmonary thromboendarterectomy, isn't it?
Yes, sir.
Coming week, Dr. Rajdeep will be presenting on the operative steps of PT, sir.
Yeah, okay. That Julius will be there, or
Yeah, you should also you should include the treatment, which is non-operative treatment as well.
Yeah.
So there are primarily three forms of treatment. So you should, I think, cover all three of them in that.
I think so. Especially the newer anti-pulmonary hypertensive drugs and the role of pulmonary angioplasty and after surgery or people in whom you can't do surgery. And what are the signs of inoperability for a pulmonary thrombo in that? That you have to discuss in the next class. Okay.
Okay.
You should all know that we are also part of the international Cteph registry. We also contribute data to the registry. We are probably the only center from the country.
Okay, then thank you very much. Thank you, Julia. Thank you.
Thank you.
Thank you, sir. Thank you, sir.